Hello, I'm Dr.Roja sugumar, consultant in obstetrics and gynecology, working in Madhu Super speciality hospital. I completed my MBBS and DGO in MVJ Medical College, Hoskote. I'll be discussing about hypertensive disorders of pregnancy today. Why I have chosen this topic is because about 8 to 10% of total population of India, they come with a hypertensive disorder of pregnancy. And when 10 patients walk into your OPD, at least one person will be associated with this disorder. And hypertensive disorder in pregnancy, when do you say it is hypertension? In pregnancy, let's first see what is normal. BP actually reduces in pregnancy because the peripheral vascular resistance reduces and all the blood vessels undergo vasodilatation normally. Whereas in hypertension, what happens? There will be increased resistance and it occurs at 20 weeks. That is where the placental mechanism occurs in pregnancy. We'll divide this hypertension into 4 categories and later I'll tell you why I'm explaining these categories to you. First, gestational hypertension, then comes preeclampsia, then comes chronic hypertension. The last one is preeclampsia superimposed on chronic hypertension. When it comes to what is hypertension actually, when the BP reading is more than 140/90, and you will not take just one BP reading because when the patient comes into your OPD, she will be having anxiety or she would have traveled, the panic attack might be there. So you will consider 2 BP readings and you will leave a gap of 4 hours between both the BP readings. And when both the BP readings are equal to or more than 140/90, you you put it into hypertensive disorder of pregnancy. And gestational hypertension is when the BP reading is more than 140/90, as I said, 2 readings 4 hours apart, and it should be more than 20 weeks of pregnancy, not before that. Then you call it as gestational hypertension. Preeclampsia is the same thing, gestational hypertension, but it is associated with proteinuria or any end organ damage. I'll tell you what is end organ damage later. Proteinuria, for protein in the urine, we need not wait for the lab investigations. As the dipstick is available in our hospital, we do it in the OPD basis and report it immediately to the patient. So they need not worry about it. And end organ damage. How will you diagnose end organ damage? We'll ask the patient for the symptoms, like she'll be having epigastric pain, severe pain. It will be because of liver involvement. Liver damage can occur in preeclampsia. Renal damage, which will be occurring first, that will present as proteinuria. For renal damage, you will send for this one kidney function test to see for urine creatinine. That will be elevated in hypertensive preeclampsia. And in liver damage, SGOT, SGPT will be elevated. And cerebral damage, for that brain damage, how do you find out? You'll ask the patient for the symptoms. Do you have giddiness, blurring of vision, headache? If the patient has convulsions, you call it eclampsia, where you have to deliver the patient immediately. And pedal edema, we see for swelling of the legs, but it is not very significant because it occurs in pregnancy normally. If the patient says the pedal edema is increasing, the swelling has increased very badly, then you have to rule out hypertensive disorder. Then next is chronic hypertension. Here the patient will be having BP even before she becomes pregnant or during first half of pregnancy, that is before 20 weeks period of gestation. Last comes preeclampsia superimposed on chronic hypertension. Here the patient will be having all the preeclamptic changes like headache, she'll start developing end organ damages like I told you, liver damage, cerebral damage, pulmonary edema can occur, it can affect the lungs, or renal failure can occur, any of the end organ damage can be there, or proteinuria may worsen in the later half of pregnancy, but she will already be hypertensive even before the pregnancy. This is the last part of our description of hypertensive disorders. And why I told you about the different types of hypertensive disorders is because we treat the patient based on type of hypertension they have. Okay, if it is gestational hypertension, we don't treat them if the BP is under control, or we put them on mild dose of labetalol. Okay, when it is this one preeclampsia, what we do, We monitor for the BP readings, and if it is not at all controlled, if it goes above 160 by 110, what the treatment of choice is termination of pregnancy. Delivery of the placenta and the baby is the treatment of choice here. If the patient is undergoing any end organ damage, then we will not wait. Whereas if there is chronic hypertension, if she had hypertension even before she became pregnant, then what do? We will ask her for what medication she was taking, because some medicines like atenolol, metoprolol, they contraindicated in pregnancy. We need to stop that drug, and we have to start her on labetalol. That is the reason we have to find out about the chronic hypertension. And lastly, preeclampsia, if it is associated with convulsions, that is seizures, fits, whatever you call, then we have to terminate the pregnancy, whatever the period of gestation is. And not only the patient, regular follow-up is required, not only for the patient but also for monitoring the baby, because we have to do regular scans, and 24/7 in our hospital regular scan is available with Doppler facility also. Why do we do regular scan? To see the growth of the baby that will be affected grossly in hypertension of pregnancy and in preeclampsia mainly. And the other thing is we will do serial Doppler checkups, because we need to know about the blood supply to the baby, and it may lead to IOGR in pregnancy. Okay, when the patient has to become very cautious in pregnancy is when she starts perceiving the fetal movements less. Then she has to come immediately to the hospital. They should not delay. I've seen patients saying that my grandparents said it is normal to have fetal movements less. That is, it is not going to be helpful. They have to visit the hospital immediately, because we'll be able to help them out. And if there is bleeding, because hypertension can lead to abruptio placenta, they have to come back immediately to the hospital. And impending signs like headache, giddiness, blurring of vision, or epigastric pain, if she notices anything like this, she has to come to us immediately, and 24/7, and the treatment as well. Thank you.